Someone is disturbing. Who is that? Can mute that person?
Yes, you can start, sir, please.
Yeah. Good evening, everyone. Welcome. Thanks to Roche, Intas, and Zydus. We are starting our webinar, that's panel discussion on busting myth and facts about HCC management. This moderation followed by another two very interesting topic, one by Dr. Akash Shah and one by Dr. Kshitij. So let us start this webinar with the HCC management. And my disclaimer is that all content in this presentation is intended for healthcare professional, and Roche India does not promote or support the use of medication that is manufactured by it in off-label indication. And all suspected adverse event and special situations complaint is associated with the use of Roche medicinal product, please report the same to the India Drug Safety at roche.com. So let us start. We had total 5 to 6 panelists. Can everyone just have a one introduction? Every panelist, starting from Dr. Bhavesh Thakkar.
Good evening, all. I'm Dr. Bhavesh Thakkar, gastroenterologist. I'm working at Marengo Sims Hospital along with Dr. Bhavesh Parekh sir, related to malignancy-related patients. And I'm there for last 12 years duration. We do commonly see HCC patient, and I do manage partially along with conjunction with Dr. Bhavesh Parekh. Thank you.
Over to Dr. Amit Jetani.
Hi everyone, I'm Dr. Amit Jetani, onco-physician at Rajkot, practicing here since 11 years. We have our own Century Cancer Hospital, and sir was our professor and teacher, mentor. Thank you, sir.
Dr. Priyal, please.
Good evening, everyone. I'm an onco-physician practicing at Kiran Hospital, Surat, since last 3 years. Yes.
Dr. Mohit, please. Dr. Mohit.
Am I audible, sir?
Yes.
I'm gastroenterologist from Surat. I'm in SITS Hospital, Surat, from last 5 years, and we do see so many patients of SCC, and we have 2 oncologists there in our hospital.
Dr. Aditya.
Good evening, sir. So myself, Dr. Aditya Mehta from HCG Cancer Center, Baroda. I have been practicing as a medical oncologist since last 6 months, along with Dr. Pinaki Mahato. Thank you.
Dr. Chintan is joining. So we had 2 gastroenterologists and 3 medical oncologists. Is it right? Anand or Nirav?
Chintan sir join, sir. And yes. Dr. Aishal Parmar will be joining in 2 minutes.
So Dr. S.L. Parmar is gastroenterologist or is a medical oncologist?
Yes, sir, gastroenterologist.
Perfect. So there is a combination of gastroenterologist and medical oncologist. Right. So start. That is a BCLC and ESMO guidelines for treating the unresectable HCC. So whenever advanced HCC, the portal invasion and or EHS, preserved liver function and performance status 1 and 2. The systemic treatment for unresectable HCC, if we are expecting more than 2 years of expected survival, then the BCLC guidelines, this is very important, that is updated in 22 last. The first line is Atizo plus Biva or Durva plus Tremiluk, like immunotherapy plus anti-VGF or IO plus IO. If not feasible, then the first line is sorafenib, lenvatinib or durvalumab. That also mentioned if not feasible. As far as the ESMO guideline is concerned, Atizo plus Beva again is the first line. Option has given sorafenib or lenvatinib. Again, second line treatment option, that is post sorafenib, we can give regorafenib, cabozantinib, ramucirumab, and if that again not feasible, then we can go for clinical trials. The post atizo plus beva we can give for clinical trials. Post durva plus tremelimumab go for clinical trials, and post lenva or durva also go for clinical trials. The third line, cabozantinib. Cabozantinib is also given in the second line post sorafenib. So again, in the ESMO guidelines, it is almost same that if you had given atizo plus beva, then you can give rigora, cabo, and ramucirumab. Or if post lenvatinib, also you can give sorafenib, cabozantinib, and rigorafenib. Again here, the post sorafenib they have given like rigorafenib, cabozantinib, and ramucirumab. So again, this is the very important. We are starting with the guidelines of the advanced HCC and systemic treatment. The treatment goals is very important. If the patient population like BCLC-B or BCLC-C, if it is intermediate risk, the test suitability, if it is suitable, then go for test. If it is unsuitable, go for lenvatinib or atizo plus beva. And from atizo plus beva, you can go for lenvatinib, or from the test, if it is refractory, then go for lenva, atizo plus beva, durva plus tremi, and the other lines. So that's the again same guidelines. The recent phase 3 trials in advanced HCC, that is again in 2020, 21, 22, 23, and 24. If again it is intermediate stage, test or test plus sorafenib. If it is advanced stage like BCLC-C, the SARP trial, that is for sorafenib, reflect trial for lenvatinib, IM Brave 150, that is atizo plus beva, checkmate 459 for nivo, rational for tisletizumab, cosmic 312 is atizo plus cabo, lip 002 is pembro plus lenva. Himalaya trial is very important trials for durva plus tremelimumab, and CAS 310 it is camrelizumab plus rivocerimab. Again, emerald trial or the lip 012, if TES and lenvatinib has been in 23, that is launch trial, and in 24 emerald 1 is TES plus durva plus beva trial. So this is also very important. This is the schematic presentation of recent phase 3 trials in advanced HCC. Now, my question to the expert panelists, the first is to the gastroenterologist. Anyone can answer that what has been your experience in selecting first-line therapy for undifferentiated HCC? Any gastroenterologist?
So up till now, we were using only lenvatinib in advanced STC.
Okay.
But after coming with atizolo plus bevacizumab, we have used in 2 or 3 patients with portal vein thrombosis, and the results are good, sir.
Any medical oncologist?
Yes, sir. Previously, before introduction of immunotherapy in HCC, our choice used to be definitely, 10 years back it was sorafenib, then lenvatinib. But now the first line is atizobev or durva plus tremelimumab,
Perfect.
depending upon comorbidities and contraindications.
So comorbidity and contraindication is also very important, as Dr. Jitani mentioned, because sometimes the selection of that first line therapy is very important. Now, what are your thoughts on the patient selection criteria of this pivotal phase 3 trials for the systemic therapy? Again, as mentioned Dr. Jitani, the patient selection criteria like comorbid illness or the any condition that can not giving that systemic therapy. So again, Dr. Jitani, please, what are your thoughts on patient selection?
Primarily for HCC, we the first thought comes to our mind is the liver function. How is the child book score, A, B, or C? If A, he's eligible for all the systemic options. B, the option shrinks, and C, it's just best supportive care.
Correct.
So yeah. Plus, whether patient having contraindication to immunotherapy, right? Like any autoimmune conditions are there active, or a contraindication for bevacizumab, like a history of perforation, bleeding, an history of embolization, that will guide my choice of therapies.
Priyal, your thought process?
Yes, sir. So basically, what we choose before selecting any treatment is the compensation, or the, as sir rightly mentioned, the child pug scoring. So practically, most of the patients that we see are either an advanced BCLC-B, that is B7 or higher, and BCLC-C. So where we tend to either for symptom control, sorafenib, which can be used, but BCLC-B, if it's higher criteria, we look for other factors like the tumor burden, if the patient has any decompensated variceal bleeding or something like that. So the performance status of the patient, the relate means the causative factor of HCC, whether it was viral related or another factors. So those all factors play an important role in choosing our treatment.
Perfect. Bhavesh Thakkar, when the patient came to you and when you refer to a medical oncologist for any treatment or systemic therapy, what is real world like? How the patient is presented of HCC to you?
See, most of the time we see advanced disease patients. So, as per phase three trials, and we discussed, we do not see that ideal cases for the atezolizumab and bevacizumab typical. Most of the time, they are child B advanced or child C disease, or they are having advanced disease with decompensation in form of ascites, encephalopathy, or bleeding risk. So, these are the confounding factor which limits the treatment.
Correct. Correct. Any thought process on Dr. Aditya, please?
Yes, sir. So most of the patients which present to us, they are in advanced stage. Mostly the patients, they present with fatigue, weight loss. There could be ascites, and the sir, talking about the trial, the cohort which has been taken in the trial, I think it is a little healthier than what we see in the real world. So usually the patients that present to us are ECOG performance score of 1 or 2, and child pug score either A, B, or it could be C. So the trial, in the trial, the cohort which they have taken is mostly ECOG performance score 0 or 1, and the child pug score A.
So you know that, or you want to tell that most of the our real world patients in might be more in B and C rather than A, and most of our the performance status is 1 or 2 rather than 0 and 1.
Yes, sir. Not
Okay.
about sir, child pug, it could be A or B. C very less, but ECOG performance score is either 1 or 2.
Perfect. So finally, this is I am Brave 150 trials, and that they have selected unresectable HCC, no previous systemic therapy. They have BCLC stage B or B stage C, the child flu class A, and ECOG performance status 0 to 1, as Dr. Aditya mentioned, and patient with main portal vein tumor thrombosis include. So question to Dr. Bhavesh Thakkar, that how common that is portal vein thrombosis, and how important if you suggest any treatment for that.
Uh, Portal vein thrombosis definitely is an important aspect when we are considering treatment for HCC, because if portal vein thrombosis is there, TACE therapy most of the time we cannot do. So all these patients are usually, when they come with advanced HCC, they are for systemic therapy. If possible, only we can do that. And most of the time when they develop portal vein thrombosis, they have refractory ascites, so that creates a trouble.
Perfect. So finally, when we look in this I am Brave 150, or this is the criteria, and they have randomized from atezolizumab plus beva versus sorafenib. As Dr. Jetani mentioned, or might be another panelist mentioned, that initially we are giving more sorafenib or lenvatinib, but nowadays atezolizumab plus beva had a very good result. So this is the I am Brave 150, and the primary endpoint or OS, if you look the curve, the HR is 0.66, the 95% confidence interval is 0.52 to 0.85, and the even at the end of 24 months, the cow separates or the OS compared to like sorafenib, the atizo plus beva, that is a blue line, is 13.4 versus 19.2, as well as PFS. This is also very important. The PFS again, it was even at the end of 6 months, the cow separated, and it was 4.3 for sorafenib and 6.9 for the atizo plus beva. The response rate, overall response rate was 30% versus 11%. Complete response is 8% versus only less than 1%. And DCSR, that is durable complete response, is 74% versus 55%. So finally, if we look this, now the question is that how do you interpret the OS data given that we don't have any head-to-head comparison study, KM cows, that is Kaplan-Meier cows separation, HR and risk reduction, response rate, and durable response. Dr. Amit Jetani, please.
Uh, Sir, whensoever we are using this immunotherapy because of cost, we have to show to relatives, patient that these drugs are working. And many a time there is a pressure from them side too. So we need a good drug with a good response, a good shrinkage in the tumor, early separation of the curve, and durable response and minimum side effect.
Yeah. Dr. Aditya, please.
Sir, I think there is a pronounced divergence in the Kaplan-Meier curve, and it correlates with the overall survival also. And the hazard ratio of 0.58, that also outperforms the historical sorafenib.
Dr. Priyal.
Yes, sir. So actually, the head-to-head comparison is not feasible, as we said. But looking at all the studies, Atezo-Bev, the IM Power study had the earliest suppression with a sustained response. Even in the Himalayan study, also the suppression had been later, but it was sustained. So saying that immunotherapy does work when the tumor burden is high. But comparing all these three studies, if we cross compare, then the overall response rates were highest in the IM Power study. So we can show the comparative of the three studies to guide the patient regarding choosing the outcome in a suitable fit patient who is well preserved.
Perfect. So if we go ahead, the prioritized requirement for the first line systemic therapy is wide benefit. It should be less toxic, the higher response or low progression, long PFS as well as OS. So this is also very important, and less grade 3 or 4 treatment related adverse event, preservation of the liver function, and the subsequent therapy also. This is also very important. So if we select the treatment and this KM cow separates at 1 to 2 months, here they are starting separating from 1 to 2 months. This is also very important. Even at 6 months, at 12 months, and 18 months. At 6 months, it was 72% versus 85%. 12 months, it is 56 versus 67. And even at the end of 18 months, it is also cow has been widely separated. If in other like this for Nivo or Nivo plus EP versus Lenva and Sorafenib, the cow has been crossed before it separates. So it separates at 24 months, and before it was already crossed. So this is also very important. And again here, the stride or versus sorafenib, again here, the KM cow is separate from about 6 months, not till 1 to 2 months. So this is very important as far as the atizo plus beva is concerned, and median OS is concerned, and stratified HR is concerned. The efficacy and safety of the atizo plus beva for advanced hepatocellular in the real world, and this is a single arm meta-analysis. So if we look in this network meta-analysis of the phase 3 trial, atizo beva versus other. It may be different thing. Here it compare with Lenva, here it compare with Sora, here it compare with Durva plus Tremi. Again, the most important part, that comparison again with the various things, and the A plus B is definitely much better compared to so many comparison. So I am Brave 150 or the responder analysis, if we look to the p value, either it's for complete remission plus partial remission, if it is stable disease, if it is progressive disease. Here again, the HR is 0.11 and p value is 0.0001. Again, 4-month landmark and 6-month landmark. Again, all the three curves has been separated very widely. So this is also very important as far as Atizo plus Beva is concerned. If we look to the waterfall plot, again for IMBRAVE 150, this is also very important that 74%, the tumor shrinkage population is 74%, while in sorafenib it was 54%. So again, if we look the various things about Atizo plus Beva compared to sorafenib, and again that is very important that this combination is much better. The duration of response, sometimes for a immunotherapy it is the tail part, or it is the most important, that what about the duration of response. If we calculate even at 24 months, this is also at the end of 2 years, this is also very important that it responds for a longer duration of time. So final conclusion, the three factors of the tumor response for long term survival: high response rate, deep response, and long response, the Atizo plus Beva, it satisfied all three factors. Now, again my question to a various panelists, that can Atizo plus Beva be used in patients with varices? Initial talk also, Dr. Jetani and Dr. Other also panelists mentioned that whether the patient selection and how do you approach this patient in real world. So first my question again to a Dr. Bhavesh Thakkar, gastroenterologist, that whether your patient or patient came to you because as a gastroenterologist patient might be, even HCC patient might become with the esophageal varices. Whether are you, whenever you refer to a medical oncologist, are you treat varices first, or can you guide medical oncologists that please select the drug that cannot do worsen for esophageal varices?
Yes, usually as per protocol, any patient with cirrhosis and HCC, we do screen for esophageal varices. If the patients are having grade 2, grade 3 or higher varices, we do band ligation, we properly control that, then only we refer. And I also support that Atezo Viva can be used when we control varices properly, then we can consider for that.
Excellent answer. As far as the gastroenterologist is concerned, that if at all we had investigated or we know that esophageal varices, and by treating of by ligation or by band ligation, then again medical oncologist can be given atizo plus beva. What about Dr. Amit? Can a proper treatment or proper diagnosis or screening for esophageal varices is also very important? If your gastroenterologist has not done, are you sent back to at least investigate for esophageal varices, because might be our HCC patient underground or background is cirrhosis of liver? Dr. Amit?
Yes. Yes, sir, absolutely. We do screen them for varices with SCOPY. And if intermediate to severe varices are there, and if they indicate bending, then I recommend them treat them, and then only we start with our systemic therapy.
Dr. Mohit or Dr. Chintan, your comment, please.
Uh, so usually we also do endoscopy for varicose screening. If they have a high risk varices, we do band, and then we refer the patient to the oncologist.
Okay, Dr. Chintan, please. Dr. Aditya?
Yes, sir, same. So majority of my patients, they undergo endoscopy, and either banding or sclerotherapy for grade 3 or grade 4 varices.
Perfect. So finally, in patient with varices, atezo plus beva demonstrated efficacy benefit over sorafenib. In IM Brave 150, the OS, PFS, and overall response rate, all three benefit were observed among patients with varices treated with atezo plus beva. So this is also very important. The 15% of BCLC-B and no recent bleeding in stride. IM Brave included patients with treated varices within 6 months. So this is also very important that this type of trial they have included the patient also. In the IM Brave 150, the intention to treat population, the majority of bleeding event that is with atezo plus beva were unrelated to varices. This is also very important. What are the other causes? There might be bleeding because of the epistasis, bleeding because of the hematuria, bleeding because of the gingival bleeding, esophageal varices hemorrhage, GI hemorrhage, rectal hemorrhage, upper GI hemorrhage, hemoptysis, and peritoneal hemorrhage. So these all, and again, if that is grade 1 and 2 is more rather than grade 3 and 4. So again, this is very important, like hematuria only on 0.3%, again rectal hemorrhage 0.3%, upper GI hemorrhage is 0.6%. So this is also very important. Now, again back to the gastroenterologist. Whether etiology matter, like if the etiology of HCC, so like we had seen so many patients of alcoholic cirrhosis or non-alcoholic cirrhosis or another NSH or SH. So from gastroenterologist point of view, does etiology matter or not? Dr. Bhavesh, please.
As such, if we are considering treatment aspect, etiology matters in the fact that we need to treat if they are related to hepatitis B and C, we have to treat simultaneously hepatitis B and C. Otherwise, if we see outcome perspectively, then even whether it is viral or non-viral etiology, treatment option remains same or it may not affect that.
Any other gastroenterologist comment whether it was viral or non-viral or hepatitis B or C, or as again esophageal varices, are you able to treat this, or whether etiology matters or not matters?
I think so. Etiology doesn't matter whether it's a viral, non-viral, whether it's a alcoholic. The systemic therapy response remains the same.
Perfect. Perfect. Priyal, your comment on the etiology of HCC or any make difference for the selection of the therapy?
So only to say that non-viral usually present with a decompensated phase. So mostly alcoholic will present with a decompensated cirrhosis more often as compared to a hepatitis related. So that will only matter in selecting treatment. But overall, the choice of treatment, if they are presenting with the same stages, should not matter.
So again in IM Brave 150, the PFS and ORR benefit for atezo plus beva were observed across non-viral and viral etiology, as well as the OS benefit was also observed in the viral population also. So this is as far as the etiology is concerned. No difference in the overall survival between MAFLD versus viral etiology. If the 501 patient underwent randomization, 336 patients assigned to receive atezo plus beva, 57 patients with legal, regulatory, or contractual constraint to data sharing, the remaining 279 on the post hoc analysis, the NFLD, HCV, HBV, or alcoholic liver disease, almost all are, irrespective of that etiology, they are responding. So conclusion is that does etiology matters? And again, as far as the etiology is concerned, and as far as the OS and other thing is concerned, that overall response rate were similar. The pooled PFS in the viral group was 7.44 months and 5.5 even the in the non-viral group. So in the systemic review and meta-analysis, there is no significant difference in OS between non-viral and viral etiology. Finally, concluding that what is your real world experience with Atiso plus Beva medical oncologist, starting with Priya. Priya.
Yes, sir. So basically, it has been no major constraints as to say. The tumor response has been good when we have started with Atezo-Bev. The tumor shrinkage has been adequate. The only side effect for one or two patients we had seen decompensation with variceal bleeding, if even if it was ligated within the initial 6 months of treatment, which was managed medically. But overall, to say no toxicity constraints as such, major one.
Dr. Amit, please.
Uh, yes, sir. As Dr. Priya mentioned, the drugs are very well manageable, very minimal toxicity, and at least we can achieve something in HCC2 with these two drugs compared to past.
Other medical oncologists, please.
So in my practice also the results are consistent with the trial with a significant tumor shrinkage and a PFS of around 6 to 9 months.
So, Dr. Mohit, suppose the patient has already referred from your side to a medical oncologist, and there is some complication, as Dr. Priyal told, that might be one or two patients. So, is that medical oncologist sent back to you, and you can again manage that complications related to varices or related to altered liver function, and can continue Atizo plus Biva in your real world experience? Any experience?
Not sir, not so much.
Perfect. So now, if we look for the AB real, the first global observation registry of in routine clinical practice, USA 4 sites, Europe 8 sites, and Asia again, Japan, Taiwan, and Korea. The study population has been 433, eligible is 296. The primary objective is describe the uptake of Atiso plus BY in multinational registry, and endpoint is OS and AFS or OS and PFS. So finally, the baseline characteristic again AFP more than 400, that is in 34.5 percentage. Child pook 5 and 6, cirrhosis present in 75%, and etiology the most common is hepatitis B is 40%, non-viral is 24%, and again for hepatitis C is round about 25%. So finally, this is the efficacy summary, that is AB real, and the AB real global observation study confirms the reproducible safety, tolerability, and efficacy of Atiso plus Beva in routine clinical practice. The real world study Taiwan long term survival outcome, the 54 patient male 95%, hepatitis B 68%, median follow up time is 79.1 month. Median OS 19.6 months. 16 patients had an OS more than 36 months. So from the data collected in 4 medical centers in Taiwan, A plus T lead to a notable proportion of patients achieving long-term survival. 60-month OS is 19.6%. So finally, how has been your real world experience with VP4 patients? Again, VP4 versus non-VP4. The VP4, again, that subpopulation with Atiso plus Viva displayed 38% reduction, and two arms saw similar grade to 3 to 4 adverse event regardless of the VP4 and non-VP4 subpopulation. So this is also very important. Again, subpopulation. Finally, do you worry about bevacizumab skip dose in your patients? So sometimes, Dr. Jitani, because of some bleeding or some complication, if your
Right,
patient has skipped the bevacizumab, they have continued atizo, but
right.
because of some reasons, are you worried about that skip doses, or you can continue atizo?
Practically, we can continue with atezolizumab
Correct?
because there are other single immunotherapies also there in guideline.
Correct?
but a bit worried for the long-term outcome because we are not giving as per the regimen. So,
Correct. Dr. Aditya, please.
Yes, sir, I agree with Amit, sir. So, if the patient has any bleeding manifestation and he or she skips bevacizumab, we can continue with atezolizumab practically.
So again, in this slide, the IM Brave 150, the exploratory analysis of the association between BEVA skip or delayed and treatment outcomes in patients who skip bevacizumab due to AE, there was no significant impact on the efficacy and safety of the Atizo plus BEVA. This is also shown in this particular slides. So finally, to conclude our presentation, the patient quality of life, liver function, it definitely correlate between the prognosis and the treatment availability or the subsequent treatment. So subsequent therapy, this is also very important. Aditya, what do you feel if we use Atizo plus Beva, your subsequent therapy whenever the patient progress, again whether it makes any difference or the second line therapy is also your point of view is very important or not important at all?
Yes, sir, definitely. The second line therapy is also important. So once the patient progresses on ATES-BEV, till the performance score of the patient, most of my patient, it remains same, and patient easily tolerates the subsequent therapy.
So what is your selection of the subsequent therapy?
So subsequent therapy, as you mentioned in the earlier slides, it could be a single agent immunotherapy. It could be immunotherapy plus a target. It could be single agent TKI.
Perfect. So now this ESCO GI 2025 latest, the abstract 600, the long-term survival outcome of Atizo plus Beva in patients with advanced hepatocellular, where the Atizo Beva treatment lead to a notable proportion of the patient that is achieving long-term survival, and 60-month OS is 19.6 month, 19.6 percentage. So again, the OS in Taiwan, again, overall response rate is 34.5% with median OS of 19.6 months. Again, it is very important that very long, up to 60 months also, that is a very good thing. So finally, this positive phase 3 frontline in advanced HCC, that is IM Brave 150 and Himalaya trials, and the control is sorafenib for both. Again, portal vein thrombosis is included, HR 0.58, median OS is 19.2, again, median PFS is 6.9, and the resist criteria or overall response rate is 30% with Atizo plus Beva when we compare with sorafenib. So question to the expert, in clinical practice, how many high risk patients do you see in HCC? Dr. Aditya, please.
So around 60 to 70% of the patients who present, they are in advanced stage in my
Dr.
practice.
Suriyal, please.
Yes, somewhere around 50 percentage.
Dr. Amit.
yes, sir, around 60% are high risk.
Dr. Bhavesh.
Sir, I agree with Dr. Amit and Dr. Aditya. Most of the patients are high risk.
Right.
More than 50% or more than
Yeah,
70%?
more than 50-60%. Yeah.
Dr. Mohit.
So more than 50-60%.
Yeah. I think Dr. Chintan has not been, is there or not given any answer. Dr. Chintan, are you there? It's okay. So finally, I am Brave 150 and this Hipatorch, this whole trial, both trials is very important. In Hipatorch, it is a toripalimab, and in this I am Brave 150, it is Atizo. It is a global randomized open label phase 3. In Asia, it was 40%. The hepatitis B virus is 48%. Median OS is 19.2 months. Median PFS is 6.9 months. CR is 8%. Overall response rate 30%. Subsequent therapy use is again very important. 36% in IO arm and 52% received subsequent therapy. Grade 3 or more AE is 45% globally. Upper GI bleeds is only 2.5%, and high risk patient included, that is almost 20%, while in hepatology the high risk patient has not been included. So my question or my conclusion is that again local immunotherapy, again toripalimab, that is PD-1 inhibitor or that is a Chinese immunotherapy or local immunotherapy. Amit, your comment on other than atizo any immunotherapy or so many now local immunotherapy came, what is your
Right.
experience or any of that?
Sir, we are very much, I mean, used to with all the atezopambro, nivolumab, and now enough faith is also generated over them. But the Chinese are coming with new immunotherapy with lesser cost, so that way it's our choice is bit tilted toward it also because of the cost only.
Priya, your comment with local immunotherapy?
Yes, sir. So practically, we don't have experience, but sometimes because of cost constraints and if the patient is fit enough to receive immunotherapy, then it may be offered rather than just switching to a TKI alone.
Okay. So my concluding slide is that atizo plus beva in the management of HCC leads to overall survival prolongation, benefit regardless of the etiology and VP4 status, good direct anti-tumor effect, manageable side effect, preservation of quality of life, and preservation of liver function for the subsequent therapy. Thank you. Thank you very much. Thank you, my all the panelists.
Thank you, sir.
Okay.
Over to Nirav.
So if you can just invite Dr. Kshitij.
Yeah, I'm inviting Dr. Sitit Damodaria, a consultant medical oncologist of HCG Astha Cancer Hospital, Ahmedabad, for the next topic. The topic is liquid is solid in NSCLC. Over to Dr. Sitij.
Yes, good evening, everyone. Thank you, Dr. Bhavesh Saib, for giving this wonderful opportunity. And so, the topic which is given to me is liquid is solid in today's world. In lung cancer today, the biggest threat is not the lack of drugs, it is basically the delay in molecular diagnosis. So every week we wait for a report, but the tumor does not wait for us or the patient. So the real question is not tissue versus liquid, but how do we use both very wisely to save time, save lives of our patient. So with that, I just would like to share the screen if this is possible. Uh, Share the screen.
Sir, should I share?
Okay. 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 Fine. That is okay. 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 Next slide. So, okay. So this slide shows how common lung cancer is in India. So if we consider the most commonest malignancy in males in India, it is definitely oral cavity cancer. But second to that, it will be lung cancer. And if we consider mortality wise, lung cancer will be the cancer which is number one as far as the cancer mortality is concerned. Some interesting facts which are mentioned over here is that 87% of male patients are smokers compared to only 27% of female patients. And the incidence is rising among women. Next slide. Now, this is showing 5 year survival rates over time. Quite an old analysis, but if we can just compare countries, if we see India, next slide. So, if you can see the 5 year survival rate over time, this has somewhat remained stable or slightly lower if we compare it with the other countries, where over a period of time it has improved. Now, obviously, it's this bit old analysis, but yes, this is something which is worth noting. Next slide. Okay, so this is what the guidelines recommend as far as the molecular testing in stage 4 non-small cell lung cancer is concerned. Very heartening to see that the list is quite exhaustive, and this list is growing day in and day out. It has moved beyond just EGFR and ALK, and it has included ROS1, BRAF, NTRK, MET exon 14 skipping, RET, KRAS G12C, EGFR20 exon insertion mutation, HER2 mutation, and we have specific uh, targets, specific molecules targeting these mutations. Next slide. So 45 to 70% of our patients may benefit from targeted therapies. So this is very important to so molecular testing has become the cornerstone in management of non-small cell lung cancer as of now. Next slide. So no patient should be devoid a molecular testing. So that is the reason why it is like that, because it has changed the management of the disease in a very good way. Now this is the genomic landscape of advanced non-small cell lung cancer using the Guardant platform. And what it shows is EGFR is the commonest actionable mutation with a frequency of 28.6%. ERBB2, HER2, is 9.8 percentage. So HER2, definitely look out for HER2. We have molecules targeting this mutation. And this is not very, very uncommon. Even it is even commoner than ALK and ROS1 as per this study. Now, the important thing is the turnaround time. We all want our patients' reports to be made quickly so that we take our decisions quickly. And the good thing about this is the median turnaround time is less than 7 days. So we can get the report within a week, and I think that is very welcomed. Next slide. So this is a case of a 65-year-old never smoker woman from China. In 2016, she was diagnosed with lung cancer. It was a localized disease. It was the resection was done. Adjuvant chemotherapy was given. 2018, unfortunately, she had recurrence. There were mets involving bones, lungs, and mediastinum. EGFR testing by RT-PCR was done, and that was negative. And in such a scenario, this is in 2018, where NGS was not that commonly done, and we used to send it by EGFR by RT-PCR, ALK, and ROS by IHC. This used to be the standard by that time. Obviously, nowadays it is all NGS, and so EGFR was done. That was negative, and then platinum rechallenge was done. There was a stable disease, and then followed by a maintenance nivolumab till 2020. So this used to be the scenario prior to NGS, where we had limited options uh, of molecular testing. And we can see here the patients receiving uh, uh, these drugs. And right? So if you see the next slide, should we rebiopsy or not? The answer, yes, a rebiopsy was done. A liquid biopsy was sent and an EGFR exon 20 insertion mutation was detected. Next slide. Next slide. Next slide. So what it mentions is NGS identifies twice as many EGFR exon 20 insertion mutations as a PCR. Next slide. So integrating liquid biopsy into routine diagnostics will help more advanced lung cancer patients access optimal therapy. So we know that up to 43% of patients may not have adequate samples for complete NGS testing. We all know tissue is an issue as far as the molecular testing is concerned. And that's where exactly liquid biopsy has a very important role to play. Next slide. You can skip this. Next slide. Right. And we all know once you have a targetable mutation and you are giving treatment based on that, the outcomes are fantastic. As shown in this Kaplan-Meier curve, that the median survival is 24.6 months versus 6.2 months if you're giving treatment based on the NGS-based reports. Next slide. Next slide. Okay, so this is a 2021 IASLC consensus statement regarding tissue versus liquid biopsy. And what it mentions is, so once you get the biopsy, PDL1, ALK, and ROS1, you do it by IHC, and you send the same sample for NGS testing. That is one way. The other one is to do a liquid biopsy and do the NGS testing by that. The fact that PDL1 is something you need IHC for that. So liquid biopsy, one of the disadvantage of just doing a liquid biopsy is you cannot do PDL1 testing on that. So IHC by, so for PDL1 you need a tissue. Next slide. Yes, and the plasma ctDNA has got a lower sensitivity in detecting fusions and copy number variants. Next slide. So now if you see the guidelines, nearly all the guidelines recommend doing ctDNA to see for any targetable mutation. None of the guidelines what mention is the use of ctDNA or CTC assays in detecting minimal residual disease, and the treatment monitoring is not yet recommended. Else, in all guidelines, you have a place of liquid biopsy as far as the diagnosis is concerned. Next slide. Next slide. Next slide. So this is the NILE study. The full form of NILE is non-invasive versus invasive lung evaluation study, in which tissue versus liquid testing was done. It was a head-to-head comparison. Next slide. And what it mentioned was that plasma cell-free DNA NGS is non-inferior to the tissue testing in about 282. This is a very important study. A prospective randomized study was there comparing head-to-head tissue versus liquid, and which established the role of a cell-free DNA or a liquid biopsy NGS, and which showed it as it is non-inferior to the tissue testing. Next slide. Next slide. And if we see the now comes the question that should we be sending the first tissue and then go with the liquid as a sequential testing, or should we doing first liquid then tissue, or should we be doing complementary? So there are pros and cons to each of these sequences, each of these approaches. Obviously the pros of tissue is you can have a proper histology, you can have PDL1 testing. The cons is, yes, it may take a lot of time for that. And so you may not get a result within a week if you're doing a tissue-based NGS, which is possible by a liquid-based NGS. The negative aspect of liquid-based NGS is you don't get an idea of histology. PD-L1 testing is not done. Next slide. Next slide. Next slide. So the value is a study which is now this is a real world study. It was done on a garden platform. Nile was a prospective randomized trial. Value was a real world study. So Nile was there in a controlled environment. Value is something a real world study in which evaluated the role of plasma versus tissue NGS in non-small cell lung cancer patients, and it showed that yes, it is non-inferior. The liquid NGS is non-inferior to the tissue-based NGS. Next slide. Next slide. Next slide. Next slide. And if we do a complementary testing, it increases the number of actionable alterations which are found. We all know that there can be problems with tissue, insufficient tissue, reports after 2 weeks mentioning that the tissue is not adequate. You need to again do resampling. So all these issues we face in and day out. Complementary testing makes this negative part tackled down. Like you can have a comprehensive assay and get the results, a comprehensive analysis within a short period of time. Next slide. Next slide. Next slide. And now this is a analysis which is done from India, led by Dr. Purvish Parikh. And this was regarding the molecular testing in the middle of the COVID times. And what it mentioned was that there were about 354 respondents, that 74% of the oncologists, they start the treatment before the molecular results. And of these, 56% would switch if actionable alteration, while 12% would continue initial treatment until progressive disease. Next slide. Next slide. So detecting clonal resistance is very important. So once the patient progresses, you need to understand the molecular profile, and that's where the liquid biopsy has a great role. Next slide. Next slide. So targeted therapy resistance, liquid biopsy recommended at initial testing, but evidence based on first generation agents rather than current practice. So only 39% of the patients with first line osimertinib resistance able to have successful repeat biopsy and NGS testing. And we need to have better liquid biopsy detection of complex resistance mechanism and histological transformation. Next slide. Next slide. Next slide. Next slide. I think in the interest of time, we just move towards the conclusion slide. Next slide. Next slide. So Garden increased the tier 1 variant detection by 46% compared to this. So complementary testing is something which is the way forward. Next slide. Next slide. Next slide. So coming to the take-home messages, liquid biopsy is an important tool to ensure optimal treatment in patients with advanced lung cancer, with the potential to accelerate treatment start and avoid repeat biopsies. Concurrent tissue and plasma genotyping is feasible and significantly increases the proportion of patients with successful guideline recommended molecular testing overall and prior to initiation of first-line therapy. Comprehensive genotyping results prior to the start of first-line therapy is associated with significantly longer overall survival, in part mediated by timely delivery of targeted therapy. And these results support the incorporation of liquid biopsy in routine clinical practice alongside tissue testing, as well as in settings where tissue or time for molecular testing is limited. With that, I thank the organizers for giving me this wonderful opportunity. Over to the organizers. Thank you.
Thank you, Kshitij. It was very good talk on the solid is liquid or liquid is solid. Again, now I am inviting the next speaker. Our second speaker is Dr. Akash Shah on the role of bevacizumab in the management of HCC. Over to Dr. Akash Shah, a medical oncologist from Apollo Hospital.
Good evening, sir.
Good evening.
Just I'm going to discuss about the role of bevacizumab in hepatocellular carcinoma, advanced hepatocellular carcinoma. As
Dr. Akash, if you can just full screen the slide.
I've done the slide slow, it's not happening.
If you can just stop share and reshare again, sir. You can continue, sir.
Yeah. Um, so, um, So it's a role of bevacizumab in hepatocellular carcinoma, and as we know, there are two indications. One we have commonly used as per it's IMBRAVE 150, and one more trial I am going to discuss is the IMBRAVE 0050. And why this combination is used is the it's a some favorable immune modulation where bevacizumab it increasing the T cell infiltration and decreases the activity of immunosuppressive cells. And obviously, as we know, atizo it's an anti-PD-L1 and it promotes T cell activation. So there is a favorable immune modulation, and it increases the activity of the immunotherapy, and so such immune modulation works. There was initial interim analysis of AMBRAVE 150, which had showed that atezolizumab versus sorafenib had a median OS HR of 158, where sorafenib 13 months versus atezolizumab overall survival was not reached, and PFS for 4 to 6.8 months. So how study was done, it was actually stratified as per region, which is Asian, and in all that Asian were Chinese versus rest of the world, and ECOG PS 0 versus 1, macrovascular invasion or extrahepatic spread versus not present, and baseline alpha fetoprotein less than 400 versus more than 400. And primary endpoint was overall survival. Here it was easy to take overall survival as it's a disease bad, and survival is short, so they can finish. So overall survival was taken, and it was randomized in 2:1 fashion, that atezolizumab plus bevacizumab versus sorafenib till its progression. And secondary endpoints were duration, overall response rate, and duration of response. And till updated analysis, which was 15.6 months, and till that time 40% patients were on study in atezolizumab versus 26 percentage in sorafenib arm, and patients discontinued. Obviously it's a reverse number, it's 60 percentage is in atezolizumab and 74% in sorafenib arm were discontinued the study. And if we see the baseline characteristics, it's a male population. 40 percentage were Asian, which is Chinese mainly, and 60 percentage were PS0. In Childpug class, that's almost all were Childpug A. BCLC staging is almost more than 80 percentage were Childpug C, And if we see the etiology is 50% of hepatitis B virus and 20% hepatitis C, and others were 30%, and almost 40% of AFP more than 400, and 60% had extra hepatic involvement, and 40% were macrovascular invasion. We see the primary endpoint of updated overall survival of 16 months, where that median overall survival was reached in atezolizumab was 19.2 months compared to sorafenib, which was there in interim analysis also, which was 13.4 months with has hazard ratio of 0.66. And here important thing is the separation of the curve, as in initial first lecture only Dr. Bhavesh sir has explained that from first and second month only both curves, red and blue, sorafenib versus atezolizumab were diverged, and it continues. If we see the 6 months OS difference of almost 10 to 15 percentage continued at 12 months and continued at 18 months and 24 months also, we can see which is more important. And if we see the updated PFS also, the first interim analysis at 10 months, in that it was significant and it is continued till 18 months also, and hazard ratio of 0.65. If we see the updated response and duration of response, so the overall response rate in sorafenib arm is somewhere 10 to 15 percentage, and in atezolizumab arm which is 30 to 35 percentage, and CR rate in sorafenib arm was 1 to 3 percentage, and in atezolizumab arm which was approximately 8 to 12 percentage. And the progression of the disease, if you see the in PFS that very initial months only, there is a dip is there in the blue and red both curves, but the blue curve is almost 15 to 20 percentage progression is there in initial months, but which is almost 25 percentage in the sorafenib arm. So there was some 5 to 10 percentage more progression in initial months, which is seen in the sorafenib arm compared to atezolizumab arm, and which is very difficult for us to counsel the patient to make them understand that why this disease bad and why it's progressing. So this initial progression can be reduced by 5 to 10 percentage by atezolizumab compared to sorafenib. So in if we see the follow up of systemic therapy, uh, more than one line of the therapy, which is in sorafenib, more than 50% patient received second line onward treatment, and in atezolizumab, which is 36%. So compared to atezolizumab, more number of patients received second line treatment. So overall survival should be confounded, but still atezolizumab has shown overall survival benefit, statistically significant benefit compared to sorafenib, and large number of patients, at least 26% has received immunotherapy as second line in sorafenib arm. If we see the Asian cohort, which was actually the China cohort, and 133 patients were in atezolizumab compared to 60 patients in sorafenib arm, and the patient characteristics were almost similar how it was there in the global data. And if we see the overall survival difference, uh, similarly, it diverged from first to second month, and the difference is almost 15 to 20 percentage, and more than 20 percentage by the 18 months. So, which was not there in the global data. The difference was there in between 10 to 15%. Delta was there 10 to 15 percentage. So this is little better. This atezolizumab works little better compared to global data for the Asian population, and especially we can say the Chinese population, where hazard ratio is 0.53, which was 0.66 in the global data. And if we see the safety summary, so this sorafenib is too toxic, as we all have used till 2000, this 2020 for most of the patients. And there is a hand foot syndrome, which was the worst to manage. And I don't remember that any patient was there on the 400 milligram BD dose, and most of the patients were there on 200 milligram dose. So almost 60% of patient had grade 3, 4 toxicity. Similar number of the grade 3, 4 toxicities are seen in atezolizumab also, because of there are two drugs, bevacizumab as anti-VEGF, which is the side effects are a little different than the sorafenib, but mainly hypertension and proteinuria are there, and immunotherapy related side effects are also there. And the drug discontinuation withdrawal due to adverse events were there less in sorafenib arm, 12% compared to 22% in atezolizumab. So concluding, Ambrave 150, that almost this updated analysis at 16 months, which demonstrated statistically significant overall survival benefit, which is 13 months to 19 months with in atezolizumab with HR is 0.66, and which is more in the Asian patients up to 24 months with hazard ratio of 0.53. In median PFS also continued, the hazard ratio is same, continued at the second analysis also with 0.65, and overall response rate, which is more 10 percentage to 30 percentage. And almost safety and tolerability, the side effects are different, but the numbers are same for the grade 3, 4 toxicity. And as we know, the right now it's the first line choice of most of the oncologists is atezolizumab and bevacizumab. So I'm going to say a second study, which is after the approval of the first line treatment of atezolizumab combination, which is it's as an oncological principle that gradually it will come to the localized setting also. And as we know that in large number of patients, when we go for the surgery, resection of the liver mass, almost two-third patients will recur, especially in high-risk features. They recur, and there will be two bimodal pattern. Most of the patients will recur in first 2 years only, and second small curve will be there, that one-third patient recur in 4 to 5th year. The high-risk features are large tumor size, more than 5 centimeter, multiple tumors, poor tumor differentiation, vascular invasion. So, considering high recurrence, almost more than two-third patient recurs, if this only surgery is not enough, and some addition of the treatment is required. For high risk features, this adjuvant same protocol, atezolizumab is used. Here randomization was 1:1 for childhood A patients, and with all high risk patients, they have taken either surgically resected or just ablated in stage 0 patient. So atezolizumab versus active surveillance till progression. And primary endpoint was recurrence-free survival. Primary endpoint was recurrence-free survival. And as I said, the bimodal recurrence rate is the large number of patients recur at the 1 year, and the second peak will be there at the 4 to 5 years. And as per high risk criteria, the if after resection, if it is any tumor which is more than 5 centimeter or more than 4 number of tumors, or vascular invasion or poor tumor differentiation, and if ablation is done, then the size of the tumor is more than 2 centimeters or multiple tumors will be considered as high risk for the recurrence. And this pink bar is for the resection. So, and the number of resections are now increasing, considering the improving the techniques, surgical techniques, especially in stage 0A and B. But we know as in stage A, B, there will be high number of the high risk patients. So they need some treatment to prevent the further recurrence. So here primary endpoint was RFS, and hierarchical model was taken where that secondary endpoint of OS will be checked if primary endpoint is achieved with the number of events of 243 and hazard ratio of 0.73 with the p-value of 0.0195. The patient characteristics were it was mainly Asian patients. Almost more than 80% were Asian patients, and PDL1, if more than 60% of patients were positive, and 60% of patients were hepatitis B. So this was the primary endpoint, is the recurrence-free survival. And if we see at the 12 months, the median recurrence-free survival is not achieved till median follow-up of the 17.4 months. But if we see at the 12 months, the difference of the 13 percentage of recurrence-free survival was there in atezolizumab arm versus active surveillance after resection, and hazard ratio was 0.72, which is less than the cutoff of 0.73, and p value was also less than the cutoff, which was 0.019. Here it is 0.012. So because of that, it is achieved at the first follow-up of the 17.4 months. Overall survival was also checked. And if we see the percentage of recurrence at the 12 months in the active surveillance, which was 34 percentage compared to 20 percentage, 20 percentage in the atezolizumab. If we see this chart, forest chart for the stratified patients, so most of the diamonds are on the atezolizumab side, but most of the lines, if we see, it crosses the line of equator, and so few patients are not getting benefit by the adjuvant atezolizumab arm. And the hazard ratio is mostly, it will be in between the 0.7 to 0.78, and very specific few patients it is not cross, like PS 0 you can take, or few patients like tumor size is more than 5 centimeters. But that exactly we don't know, because for stratified patients, the numbers were less for some patients. And if we see the overall survival, it's a overall survival data which is immature, and right now it is not achieved, but it is very early to say. So right now we have to wait for the overall survival data. And as per safety wise, obviously there was no drug in the surveillance arm. So atezolizumab has the immuno and bevacizumab related side effects, and but here 60% had grade 3-4 toxicity. So concluding AMREV 050, it's the first phase 3 data which checked for the adjuvant setting, and it has achieved the primary endpoint or the event-free survival recurrence-free survival of hazard ratio of 0.72, but yet OS is not achieved. So, as per the 150, I suggest that atezolizumab should be used as the first line in the advanced setting, but adjuvant, this is the only RFS benefit is there, and curves are actually converging at the later, and OS is not achieved. So, very high risk patients, one can use it, but not for the all patients. Thank you.
Thank you, Akash. It was a very good presentation or very good clear view about the bevacizumab as well as bevacizumab plus atizo. That is I am brave 050 and I am brave 150, and various discussion about the safety and about the overall survival. Thank you, Roche, Intas, as well as Zydus, as well as thank you, Mice Ideas, to have such a good webinar. Thank you, Akash.
Thank you, sir.
Thank you, sir.